GEMS was registered on the 1st of January 2005 with the purpose of ensuring adequate provision of quality healthcare coverage to public servants that is efficient, cost-effective, equitable, and provides further options for those who wish to purchase more extensive cover. We're currently South Africa's largest restricted medical scheme with over 800,000 principal members and 2 million beneficiaries. We offer 6 excellent healthcare benefit options, namely Tanzanite One, Beryl, Ruby, Emerald Value, Emerald, and Onyx. Tanzanite One option is our entry-level network benefit option tailored for level 1 to 5 employees and is subject to network GP nomination and specialist referral rules. Beryl is also an entry-level network benefit option, tailored for members with limited healthcare needs. The Ruby option is a mid-level benefit option, tailored for members with limited to average healthcare needs. Ruby members also enjoy a personal medical savings account. Emerald is a high-level traditional option, tailored for members with average to above average healthcare needs. The Emerald Value option is our efficiency discounted option of the Emerald option, tailored for members with average to above average healthcare needs. Onyx, which is our top-level benefit option, tailored for members with above average to extensive healthcare needs. Our goal is to provide public service employees and their families with quality healthcare services at the most affordable rates. The brilliance of GEMS is demonstrated in our efficiencies to improve the overall experience for each of our members. An average of 2.9 claims are processed per second, an average of 72 registered babies per day, and we admit 0.8 members per minute per day to the scheme. GEMS truly understands the South African family and its needs. Some of our members who have discovered the brilliance of GEMS also shared their sentiments. Join us and discover the brilliance of GEMS. GEMS is an authorized financial services provider.
Ravi.
Good afternoon, colleagues. We'll just give everyone a moment to settle in as more participants are still joining. We are expecting a large audience today, so I'd like to thank you for your patience. Let's just give it a minute more. Thank you. We'll give it one more minute and then we'll begin. Thank you for everyone's patience. All right, let's begin. Good afternoon once again. A warm welcome to the GEMS Social Worker webinar. My name is Chloe, my surname is Tom. I am the Provider Liaison Officer at GEMS, and I will be facilitating today's session. Once again, thank you to all of you for joining us. We are truly thankful for the work that you do and the contribution to patient care. And just a big thanks to my colleagues as well, who've also joined us on the line, our panelists as well, and colleagues at large. So we'll begin with the intention of today's session. And really what we would like to do is to share insights. We want to align on key challenges and also, create a platform for structured engagements around key issues around social workers within GEMS. And really today's session is about alignment as well as collaboration. And we also want to strengthen this collaboration through today's discussion. And I just want to also emphasize that some of our presentation are not really about questioning the value that we do as healthcare professionals. It's really about understanding our processes, the systems pressures, as we work effectively to try and engage and align further on this. And we do have a very robust discussion, and we are going to be highlighting some of the necessary discussions such as clinical appropriateness. We want to focus on things like consistency, sustainability of the scheme is also important, but ultimately for all of us, we want to ensure that there are better patient outcomes. I just also want to start off with some housekeeping rules. And I do want for all of us to take a moment. You can take a snapshot of the screen that you're seeing there. So for our housekeeping points, please post your questions in the Q&A box. You are allowed to raise hands because at the end of the session, we are going to be taking hands as well as get your thoughts. And I will be managing both the questions and hands together. We are expecting strong engagement, so I will guide the session once we get there. Okay. So I'd just like to introduce our senior manager. His name is Mr. Ramuelo Ditswane, otherwise known affectionately as Billy. He is a seasoned healthcare professional with 25 years experience across the public sector and as well as the private sector. And he has demonstrated some expertise in the managed care sectors as well as the medical administration sectors as well. And Mr. Ditswane has been with GEMS as a scheme since 2019, and he is responsible for healthcare networks as a division, as well as provider relation. And his portfolio involves working with hospitals, healthcare providers, and the GEMS provider liaison function, which I am as one of the managers responsible for. And I'd like to hand over to Mr. Ditswane. Over to you, Billy. Thank you.
Good afternoon, colleagues, and thanks, Chair, for the introduction. Wow, finally the afternoon has arrived. We have been looking forward to having this session with our valued social workers. This has been long coming since last year, following some of the challenges that were experienced by the social workers. We have since moved on to have some direct engagements early in this year with some of the social worker groupings. And one of the tasks that came out of those conversations has been that the scheme will also go out on a national engagement, which we are now doing at this afternoon, to unpack some of the challenges that ourselves as the scheme, the managed care organization, the administration, as well as the social workers are experiencing. The intention really here is to align with the scheme's strategic objective of ensuring that we communicate, and in whatever we communicate, we do it so effectively so that the recipients of the information can find it useful and helpful in terms of their practices. And I'm sure most of you will appreciate that at GEMS, we have an open door policy. We are always willing and available to be engaged by anyone. And this is also one of those opportunities that I would love to present to everyone on this call this afternoon. Let us engage and let us be frank and honest. And we do understand that there are some areas where there is unhappiness. Please feel free to alert us, to engage us, and let us also be mindful that in all our conversations, we also need to be respectful in how we relate with one another. So, colleagues, I always say to every provider that we engage that we don't hide behind emails or call centers, and where possible and where it really matters, we are always willing and available to come in person and engage. As part of that commitment, we will also be rolling out the engagements through our provider liaison office function. So these are provider liaison officers who are employed by the scheme in all the 9 provinces. We still have to conclude on the 3 provinces, Limpopo, Mpumalanga, and Northwest, but other provinces, the colleagues are already there. So from the 1st of July, these colleagues will be engaging with the practices, meaning yourselves as our social workers, to ensure that we address some of the challenges that you are having, and also to build that relationship, because we must also admit that it has been very difficult to engage through emails or the contact center. Now we are bringing that layer as the scheme to ensure that our valued stakeholders, our valued healthcare providers are also serviced by the scheme in person where possible. So please feel free to allow them to come in when they are setting up engagements. The whole intention is not to come and spy on anyone, but rather to assist with building that relationship. And we trust that that will assist us with alleviating some of the challenges that we are having. Now, I want to also highlight that this engagement started as far back as quarter 4 of 2025, where the scheme has been engaging various disciplines, starting with hospitals. And these engagements were also focusing on the current challenges that the scheme is facing financially in terms of the high utilization that we are noticing across various disciplines that are servicing GEMS members. We started with hospitals, we addressed the issues, we did the same with GPs early this year, and then we've been moving on like that in the last week just to bring it closer. We engaged with the physiotherapist, we engaged with the occupational therapist, and today we are having social workers, and we'll continue to do so also in the next weeks with other key identified disciplines. So the purpose of these discussions around this matter is not to point fingers, is not to label any discipline as being driving or the drivers of high utilization, but is to rather point out that the scheme is facing a challenge when it comes to the payments of claims that are forever increasing. And we know that when claims are increasing, the reserve ratios are also affected. So as a scheme, then we are then put in a position to ensure that we manage that experience for the benefit of GEMS members, the benefit of healthcare providers, and sustainability of the scheme. And I'm sure all of us on this call will appreciate GEMS in the future, GEMS that is financially sustainable, that is also able to assist public service employees to have access to private healthcare that they need. So with that being said, colleagues, you are welcome, and I'm looking forward to the robust discussions, and let us also work together, hold our hands together, because we need each other in this relationship. And I'm looking forward to some of the insightful inputs that you can give to us to help us with this experience that we are having. With that being said, thank you, Chair. I'll hand back to you.
Thank you, Mr. Duswane. I'd now like to hand over to Dr. Ziyanda. Dr. Ziyanda will take us through the managed care processes. She is a GEMS fund manager at a senior fund manager at MedScheme, and she oversees strategy as well as execution across all the provider engagements as well as the health risk management. And she has a very strong focus in network contracting, optimization of system level performance. Dr. Ziyanda is a pediatrician, and her work spans again in the public sector as well as the private sector. Her professional interests include health system improvement, provider and stakeholder engagement, capacity building, and advancing quality as well as equitable people-centered healthcare. Doctor, over to you. Thank you.
Thank you so much, Chloe. I will be taking you through to the managed care perspective. Please let me know, Chloe, when you can see from your end my presentation.
We can see.
Okay, thank you.
Doc.
Right. So thank you everyone for joining this call today. We appreciate your time. And as our colleagues have noted, our discussion today is intended to strengthen the shared understanding of the utilization trend, the managed care requirement, as well as the provider processes. I think the aim here is to make sure that we have appropriate member care, better alignment, as well as sustainability of the scheme going forward. Without further ado, the intent, I think, for this slide is to acknowledge that we have seen an increasing trend in utilization, and it's more on the inpatient side, and there is some variation in utilization and intensity. What James's response or a view is for us to sit in this kind of platform, so we can discuss, what is responsible for some of these increases, and I think we will share that with our utilization, what we are seeing, so we can open a platform as a way forward, so that we do not limit necessary care, but we make sure that there is sustainability going forward. So I think what we want to say, the purpose is for us to have a shared understanding. So from a scheme, from a managed care, and from a provider, because we are all like an ecosystem that at the end of the day, we need to make sure that we are providing a service that's sustainable to the member. So from the provider's side, that means that, we have clearer expectations, we have more consistent governance, and make sure that there's a platform for us to resolve some of the gaps that from the provider, from the scheme as well, from managed care and administrative perspective, we are seeing. So it's not to reduce the necessary interventions there, but it's to make sure that the care is coordinated, justified, and it's supported when needed by our members. When we start off with the first utilization trend for social workers, we're looking over the last 3 years. And on the left, we have data for our social worker utilization, looking at both the number of authorization and the number of sessions, and then looking at the sessions per authorization. And the data is showing, and then on the right, we're looking at our membership growth over the last 3 years as well. And the data is showing that we are seeing utilization that is way higher than what we're seeing in terms of our membership growth, and it's sustained throughout the last 3 years. So it's not showing as a once-off spike, but as a continued decline, increase over time. And I think the managed care focus is to better understand this and make sure that we're focused on the justified clinical care, and that there's planning and utilization oversight for our members to make sure that we have sustainability. As we can see overall, then the authorization went up materially much higher, and the sessions as well, though we have seen a bit of a drop in the number of sessions per auth over time, and we can see membership growth went up overall by almost 8% compared to the other increases. Then when we look at it further, because it's not just about member growth, there's also maybe about providers in terms of increase in numbers. So we have on the left-hand side there, the number of social workers that interfacing with our GEMS members over the last 3 years. We do see an exponential growth, and that might likely also underpin some of the increased utilization that we've seen in the previous slide. When we look at where within our provinces the providers are, we see it's mainly Gauteng and KZN, which would obviously be where we expect the highest utilization, where there will be the key drivers of utilization based on more providers being there. We do see, though, even in the smaller provinces, as much as there are fewer providers over the last, because we're looking at 2024 to 2025, we've seen quite a rapid increase on the small provinces in terms of number of providers there. So, which would mean we'll need to align, as Billy had mentioned, that we do have provider liaison officers, so we can align on what managed care and scheme expectations in terms of working and coordinating together, where we have new providers joining in and offering services to our members. And then this slide shows utilization trends, and it's looking at the provincial trend over the last 2 years, as well as what you call monthly trends. So when we look at the provincial utilization, we can see in blue we've got 2024 number of sessions per auth, and then we can see 2025 number of sessions per auth, as well as the sessions for the 2 years in the bars. When we look at, we see that Gauteng and KwaZulu-Natal are driving the highest utilization for these provinces. And when we look across in the monthly utilization from the last 2 years, we can see that 2025 remained above utilization of 2024 until around August, with the implementation of managed care processes. Then we will see a decline in the number of sessions there. And then what we need to then make sure that we work on is making sure that we are aligning on the treatment planning as well as the clinical motivation and progress monitoring, so we make sure that the members that do need the care do get the care that they need that is clinically indicated. The slide here is just to more or less look at now once we've adjusted the utilization to membership size, where we looked at how many members we have across that province. We still see Gauteng coming through with the higher utilization, and KZN is much lower in terms of what we had seen there. So the membership side is aligning or adjusting that. But what we do see, some provinces that had low membership base and low provider base are coming up with quite much higher utilization than what would be expected. I think this is important because it shows that this pattern is not just explained by larger member bases, that there might be some utilization that we need to better understand as a scheme, as managed care organization, what are those utilization patterns in those areas. So I think the discussions would then be on that, and further deep dive into what is happening there is necessary. Then the last two slides are more looking at the outlier providers in terms of number of sessions or how high utilization volumes and number of session volumes. We looked at the top 20 providers, and we can see that it's concentrated in a few providers that dominate the usage there. So I think what we want to better understand is some of the sessions or the authorization requested and what is aligned to clinical need and care. We do know that yes, there's been increase in terms of providers, but we haven't had a much increase in terms of our member base. So I think it's more to align on some of them. Managed care focus would be on, the number of session frequency and clinical appropriateness for the services that are rendered with regards to these practices. Then what we looked at in the slides is looking at the year with the highest utilization overall, which was 2024, and looked at sessions over the year, and then divided over the 12 months and looked at it, on a workday basis. We have facilities or sort of practices or providers with about 48 sessions per workday, which I think raises questions about plausibility and a need to better understand how these are structured, the clinical appropriateness and the need, as well as the sustainability for the scheme in terms of this number of sessions. We're not saying any particular wrongdoing, but we were saying there is a need to better align and better understand, and some of the clinical or managed care protocols or processes that have been implemented are more to better understand some of these utilization trends that we are seeing. Having said that, I'm then going to hand over to my colleague, Itumeleng, who will then speak to exactly what I'm talking about when I'm talking about the managed care processes that we've implemented, so that we can better understand where it came from with our utilization trends that we are seeing. Thank you so much. I'll hand back over to you. Chloe.
Hey, thank you, Doc. Apologies for that. Thank you for taking us through that section. And we would now like to hand over to Itumeleng Sidibe. Itumeleng is the fund manager of the GEMS Fund Management team. She has a decade experience in managed care, specializing in healthcare as well as funding, benefits management, and also improving sustainable healthcare for all of us. She is a proud military woman, a pastor, and she combines discipline, resilience, as well as servant leadership to drive positive outcomes in both healthcare as well as community development. Itumeleng, I'd now like to hand over to you to take us through the managed care processes a little bit more further and give us more details. Thank you.
Itu, your sound is not coming through.
Now?
Yes, it is. Thank you.
Thank you. Good afternoon, everyone. Apologies for that. So I'm going to be taking you through the in-hospital section of the social work process, and we really thought it would make sense for us to start off with where the journey started. Based on the queries and the complaints that we've been getting, it does seem as though this is the part that's generally an area of concern. So we thought we're going to just take it quite slowly and just take everyone through it. So around 2016, we actually changed our process where previously all social workers could just get perhaps a sticker and claim against the hospital authorization. That process actually changed around 2016, where we actually requested a referral letter from the treating provider. And since that process has worked, so that's been in place since 2016. We then further went ahead and we started improving or enhancing our process where for your mental health admissions, as well as your subacute and rehab cases, you could then, so the treating doctor could then put on the DSM form, for example, that they are referring to a social worker, to an OT, the different specialities. So that's something that we started then enhancing from a process perspective. And then in 2025, around September, we then changed our process where we started requesting your progress reports as well as treatment plans, depending whether it's prospective or retrospective. This was communicated from around July till around August on the different cases. So that would be our response on around, I think, the third or fourth page of the auth letter. We mentioned that. And then communication has since gone out. And there's also a flyer that has actually gone out. But what we found is that we started getting a lot of queries and there was a lot of concerns and a lot of questions around this process. And it seemed that we needed to obviously put a lot more effort into explaining it and also do a bit of change management from our side. So if you move on to the next slide, we really just talk about this process a lot more. So for ease of reference, I have split it into a prospective process, and then the next one would be the retrospective process. So during an admission, your prospective process would be, we would require a referral letter that would need to be emailed to hospitalauths@james.gov.za. So this is while patient is actually in the hospital itself. So then we will go ahead and approve the length of stay, what we call a default length of stay. And then we would then request from you to submit a progress report. So I normally call this a daily progress report. That does not necessarily mean every single day you have to submit documentation. You can consolidate by the end of the week, but it needs to give us a view of what has happened on each day when the patient was actually being treated. So I think a lot of providers that I've spoken to are not sure what information we actually want on a progress report. So it's really us asking, what were your interventions as a healthcare provider? And if you can just give us a summarized version of what you did for that particular patient. So I'll give an example. You will say, I saw Itumeleng on the 17th, and it was a group session or an individual session. And this were the summary of what I actually did as a healthcare provider. So this information would then go to our clinical team, who will then review the information and give you a funding decision between 48 and 72 hours. So this is during admission, and it needs to be submitted to hospitalauths@james.gov.za. And then the next slide, we then focus on the retrospective process. So this is after the fact. If you can go to the next slide, please, Jay. On this particular slide, this is where it's after discharge. So that means we would then require all the information on our side. So you will still submit this information to us. So you will submit the referral letter as well as the progress report. And the progress report would then be your daily progress report. So this is a consolidated view of what has been done on a daily basis. And then also, as part of that, you will share with us the date of service as well as the type of session that has actually taken place. So I'll give an example. In your mental health facilities, there are standard processes and standard treatments that are actually done by, like in a group session. So we need to understand, was it an individual session that's being conducted that you're claiming for, or was it a group session? And it's important for you to give us that information so that the team can then make a funding decision. And then this information needs to be submitted to inquiries@james.gov.za. So I'm going to just go through it again. We will need a referral letter from the treating provider. We will need your progress report. So this is a daily progress report, a daily view of what you have done as a healthcare provider. And you must include the dates of service. You must include whether it was a group or an individual session. You also need to provide your motivation. If, for example, it is a weekend session. So this information needs to be put there upfront. Then the team would be able to make a funding decision. Now, with the retrospective process, because the patient is out of hospital, the process would take about 10 to 15 days for us to actually come back to you. This you submit to inquiries@james.gov.za. If you go to the next slide, please. So I just wanted to add the escalation process so that it's for ease of reference. So the first line, while patient is in hospital, we said you submit to hospital auths. So that means during admission, you would then submit there. If you don't get a response within the time frame that we've mentioned, you will then escalate that particular case to James Allied Escalation or ISC at medscheme.co.za. And then also, if it is retrospective, meaning after the fact, you will submit to inquiries@james.gov.za. And then if they do not come back to you within the specified turnaround time, you would also then submit your escalation to the same email. It is important to note that when you escalate, they would require the initial email or the initial request that you submitted to us, because this is the information they would need on our side. If you can go to the next slide, please, Jay. So as I mentioned earlier, we have gone and spoken to a lot of providers within the industry, just so we can get an understanding of the challenges that they're experiencing and what is actually happening on the floor. So I'm going to be just taking you through some of the things that we have noted, some of the feedback from our team, and then also I'll be taking you through some of the issues that we have established and what we're trying to do to solution. So one of the first thing is the issue of the referral letter. So some providers have mentioned that they are struggling to get referral letters from the treating doctor. I know that some hospital groups have tried to solution, and they have tried to create a hospital group referral template, because doctors are refusing apparently to give referral letters. They feel this is a waste of their stationery, and there's been obviously a lot of challenges that you are experiencing in the hospitals itself. So what we are currently busy with is we're investigating a possible template. So it will be a GEMS template that will allow for a multidisciplinary referral. So you will still require for the doctor to sign and stamp, but at least then it would be an easier process. But also, while we are busy investigating this option, it may be beneficial for you to speak to the different groups that you work with and see if they are willing to maybe put together a template, because we are trying to make this process easier. So what we also found is that because there's the struggle between the the treating doctors and yourselves, we are finding that we now get your referral letter on your letterhead as a social worker, but the doctor signed and stamped. So our team has not been accepting these, because we're obviously working on what the referral guidelines are as per HPCSA. And so that's why we are now trying to solve for this by creating a template. And we're hoping this will be out soon. But in the meantime, it is important for us just to mention, if you can speak to the hospital group, please do so. Otherwise, we are working on something. It's in the pipeline on our side. If you go to the next slide. So part of the documentation issues that we are seeing with this new process. So we have about 20 providers that we have been engaging, 20 social workers that we've been engaging, where we are trying to understand if they understand the process. And this actually helps us just to keep the pulse on what's happening. So part of what we established is that there are certain issues. So we have spoken about the letterheads, the signatures, so that's part of it. The second part is we are also seeing that some of the clinical information that we're getting, or the progress reports, are, I'm going to say, a one-liner. So as the managed care organization, we can't make a funding decision to fund for those particular cases, because, for example, I'll give an example of a mental health admission, because a lot of the people I was speaking to are in the mental health facilities. So if you are seeing a patient for 21 days, patient is admitted for the 21 days, as a social worker, you are seeing them for the 21 days, and you are requesting let's say both group as well as individual sessions, but the majority of it is individual sessions. If the progress report that you share with us is not sufficient, I'm going to call it sufficient for now, then the team would not be able to make a funding decision. And that's why I like saying a daily progress report. Maybe I should start calling it an interventions report, but we need to know on a daily basis what your intervention was as a healthcare practitioner, so that we are actually able to make that funding decision. So what we also see is that where we have received progress reports. Providers are not telling us whether it is individual or group sessions that they're actually requesting, and they actually don't give us the dates of service. So the clinical information is perfect, but we don't know when you actually saw the actual patient. And that's why also when we get daily updates, it gives us a view because we are able to see upfront. So I've been saying to the providers that we've been using as test case, or the ones as a task team, to say perhaps you in your progress report, you put your date and you say if it is a group or individual session, and then you provide us with your intervention. Therefore, it makes sense. Upfront, you know that we don't fund for weekend sessions. In certain instances, I'll give an example of mental health. So already upfront, put a motivation why the patient needed to be seen on the weekend. It could be maybe because of family, maybe the husband is working during the week, couldn't come, things like that. I think it's important for us to have that understanding from that perspective, because generally you are the providers that are seeing the patient on the ground, and we don't have an understanding. So we rely heavily on the information that we get from you. Part of it, some of the conversations I've had, providers are saying, but we submit this information to the hospital. The hospital does not give us this information. They give us an update based on their point of view and what they need to get the hospital length of stay updated. They don't give us the information, the detailed information that you put in your files. And that's why we are asking for this information from you, because we don't get that information. In instances where we do get it, then we would go ahead and update the different authorization. But as at now, a lot of the time we don't get that information from the hospital. So in terms of the delays, so because of this documentation, I'm going to call it delay, or the type of documentation that we're getting, we are then seeing a delay in your authorizations being released, because now we have all the information, we can't make a decision. So then we go back to you and say, please, can you then give us the date of service? If you go to the next slide, Jay, thank you. So I'm further addressing just the issues that I noted while we were doing this investigation. It really has helped us quite a lot, and I'm very thankful to the providers that have opened their doors and were willing to work with us to make sure that we understand their frustration. But I think it also helped us to understand when we communicate, we assume the message is clear. This exercise has really taught us that perhaps we need to communicate better, clearer. And this is why also part of these webinars, I know there was a flyer that went out recently. We will be amending that flyer and we'll be resharing it with you as well, with all the learnings that we are getting from the different providers. Part of also the issues we've noted is some of the practices, due to the frustration, I guess, they are also not following the correct submission process, and this further leads to more delays. So I'll give you an example. Because Itumeleng works for MedScheme, you then submit your query to Itumeleng and not to inquiries or GEMS. So then Itumeleng does not work on it, your query does not get resolved, then it becomes a problem. So we really do encourage you to follow the process that we've shared with you. The inquiry's email address, the hospital auth's email address, and then if there's no response, you then need to follow that escalation email address, because sending to individual staff members, cases are getting lost, and also submitting to an email address that's not the correct one. So for example, if you know there's a chronic DSP email address and you submit there, that's the wrong place. So that just further adds more delays to the actual process. So as a team, we have committed to making sure that we are continuously watching this process. So that's what we've been doing for the last few months. We have been making sure that the teams behind the scenes are routing to the correct department. We are checking the information that we are receiving, if it's of quality. And we are obviously trying to work better at communicating and making it simpler for all our providers. If you go to the next slide. Thanks. I'll pass back to Dr. Ziyanda so she can just close off the section for us. Thanks.
Thank you, Itu, and good afternoon again, colleagues. I will just be covering the last part of the presentation that's pertaining to managed care need for clinical governance and clinical information, and just speak about information sharing for patients based for funding decisions. So part of the discussions that we've had as far back as when we started this engagement, we often get the queries or questions as to why is it that a healthcare professional must share clinical information for a member? Is there confidentiality, and are they not breaking confidentiality by sharing this information with managed care organization, the scheme, or our administrator? So I think this is just to explain that this is not breaching confidentiality. The relevant clinical information is needed to so that the managed care organization can then make clinical funding decision as is accommodated for by our regulatory bodies, as you can see listed in that box there, where we talk about National Health Act, POPIA, Medical Schemes Act, as well as our HPCSA. The reason behind this is because we need as a provider submits the relevant clinical information, then the managed care organization of the scheme can then assess and make funding decision, and then we can then fund for the necessary care from the necessary benefit, so that appropriately the appropriate care is funded. And this is important so that we can control cost escalations, high utilization, and some high intensity or over servicing, as well as make sure that we protect the member and protect the scheme in terms of sustainability. Next slide, please. So just in summary, from when I started presenting to what Itumeleng presented and the closing, is that we are seeing a high utilization in terms of social workers overall, as well as in mental health, and there is some provider-related variation where we see quite extreme ends of utilization, where we need to better understand, I think, from our own analysis as we go further into this, as well as from these platforms, so that we can then have a balanced interpretation of what is happening, and then we can align accordingly in terms of making sure that the members are getting the service that they need, while we are then managing in areas where there's high utilization. So the bottom line, I think the main thing is that we need to sit in this platform and have a shared way forward of how we can make sure that both the members get the services they need, the providers are able to access members and give the services as appropriately, as well as the scheme remaining sustainable over time. As we mentioned earlier on, we do not want to see a situation where we do not have GEMS being sustainable going forward. That's all from me. Thank you very much. I'll hand back over to you, Chair.
Thank you, Doc. And thank you to you as well, Itu. We value your input and also for clarifying our matrix, our escalation matrix. So once again, to our audience, for your initial submissions where your member is in hospital, the email address again is hospitalauths, auths with an S, @gems.gov.za. We also have an inquiries, the email address that most of you are familiar with. I'd now like to introduce Chantel Mbuto. Chantel is the head of claims operations. She's also a part of our GEMS fund management. She has been working in the claims operations at Metropolitan since 2019, and she has also been appointed as a member and claims services administrator. She holds a national diploma in nursing has a qualification in public administration and also has completed his senior leadership qualification as well. So Chantal is here to take us through the claims inside as well as trends. I know this is an important area for many of us. Ms. Chantal, over to you. Thank you.
Thank you, Chloe. Good afternoon, colleagues. I hope you can hear me. My network does say it's a bit unstable. So if you can just confirm, and then I'm happy to proceed. Great, thank you. So as a start, as Metropolitan Health, we are the claims and membership administrator on behalf of GEMS. So it's my job really to share with you the benefits paid to the social worker discipline. And our first slide and graph on the top left gives an indication of the total benefit paid to the discipline. And we've brought in a 4-year view, 2023 to 2025. You can see the full benefit year and the claims expenditure that we've paid to the discipline. What this does indicate that you can see year on year, the benefit has increased significantly from 87 million in the 2023 benefit year all the way to 200 and almost 17 million in 2025. And you can see over a 2-year period, the social worker claims expenditure has increased by 33%. And if we reflect a year-on-year growth in claims expenditure, has increased by 12%. What we have also, thought to share is the current experience for the last 4 months or the first 4 months of the benefit years. And just reflecting on Jan to April experience in 2026, we paid the discipline 91 million, and you can see that that has increased from 2025, where we paid 82 million for the same period. If we reflect on the map to the top right, this gives a percentage of visits that we see within the respective provinces. And we can see that KwaZulu-Natal is the highest percentage of visits where our members has serviced or sourced the services of the discipline, followed at 38%, followed by Gauteng at 25%, Eastern Cape at 13%, and then I think Limpopo at 7%. If we reflect on the bottom right graph, that gives a view of our GEMS profile. And this is showing the demographic and utilization of our female compared to our male beneficiaries. And we can see that the highest concentration of patients falls within that female group. This is really representative of the GEMS population. We have more females as members of GEMS than our male population. And that being said, we also note, and this is across disciplines, that our female population tend to seek services more proactively or a lot sooner than our male population. And you can see the highest concentration of patients do fall within the 40 to 69 age group. And that does align with the age groups commonly affected by mental health, family, social, and other psychosocial challenges. And the growing expenditure really trend does highlight the need for closer monitoring of utilization, but also collaboration. This slide is a very busy one, and I will try and summarize it. It goes into a bit more detail than the previous slide. With the actuals from a benefit paid perspective, you'll see highlighted there in red. What we also are cognitive of is the fact that GEMS does continue to see positive member growth. And we see a number of families increasing by 1.77% and by 2.8% over a 2-year period. And we know that with increased membership, we do expect an increase in expenditure. However, when you look at the overall expenditure, it is significantly higher than what would have been expected purely by member growth. If we look at average benefit per life, year on year, that's increased by 10.3% and about 28.8% over a 2-year period. Also important to note that as the claims administrator, we do monitor the number of claiming practices, I'll say practices, and we look at the total number of practices that have submitted claims to GEMS in any particular benefit year. And you can see in 2026, this number has increased quite significantly if you compare 2024 to 2025 and 2026 respectively. So year to date, we've received claims from 1,231 social worker practices. And we also monitor first-time claiming practices, and you can see that's up by from the previous benefit year to 314. We also track the percentage of benefit that is paid to the top 10% of providers, and you can see just over half of, if we look at the January to April experience, we said 91 million. Half of that would be benefit that we pay to the top 10% of practices. So that is quite significant. I'm going to move over to my next slide in the interest of time. This slide really introduces the key trends observed within the discipline. And we do see a rapid growth in both utilization and benefit expenditure, with particular focus on mental health related conditions. We see that does continue to be a significant driver of claims. And if we look at the top ICD-10 codes billed, you can see the second top driver, well, the first one says psychiatric conditions, other, Z71.9. And you can see that, in 2026, attributed to 66.3 million of that 91 million benefit paid in the first 4 months of the year. So that is quite significant, and we do note about a 43% increase in that particular ICD-10 code, followed by major depression, and you can see the majority, or if all, could possibly be related to a component of mental health, with the exception of perhaps the Z65.8 and 9 that's listed towards the bottom of the graph. What we're also seeing across the discipline is an increased emergence of substance abuse, so alcohol and substance abuse. And you can see how significant that has increased in 2026, with just under 3 million rand worth of claims paid for that particular ICD-10 code, compared to just 500 in the prior benefit year. If we reflect on the top tariff codes, I think what we are seeing is that there is an increasing expenditure that's being attributed to the longer duration counseling and therapy sessions. I won't go through each of them, but you can clearly see if you look at the 208, 207, 206, 209, and 205, that those have increased quite significantly in 2026 compared to the same period last year. And those are, by and far the drivers of the spend that we see in the claims system. If we move to the next slide, this is a view of our total rejections. And this is again comparing the first 4 months of 2026. You can see in total just under 29 million rand worth of rejections. So if we took this 29 million plus the 91 million, that would be the total claims impact. But this is just reporting on the rejection experience. And you note that the top 5 rejection listed there attribute to 25.3 million of the rejections. At 88% of that total fees charged is attributed to these 5 top rejections. The top one being discipline not allowed for this treatment. And I saw on some of the comments already, the social worker providers asking why are the claims rejecting as discipline not allowed for this treatment. So generally, if you see a patient in the in-hospital setting, the expectation is that you will request an authorization for those services in the absence of the authorization either being approved or updated. If you submit claims, as the claims administrator, we will check if the patient is in hospital. We will then look for an auth for your practice number or discipline. If we do not find an authorization that has been approved or updated for the service states in question, then the claims will reject for discipline not allowed for this treatment. And you can see it is quite a significant value of rejections. We know that it does create a lot of concern among the discipline, and it's really in our interest to ensure that the authorizations are loaded timeously so that we can process these claims against the approved authorization. I think I just need to give assurance that once the authorizations are updated, we do actually reverse and reprocess these claims to pay against the auth. And then you can see the 4 of the top 5 very, from a cost perspective, not as significant as the discipline not allowed for this treatment, but incorrect or no referring provider populated on a claim. Especially in the in-hospital setting, it is important that the referring provider is captured on the claim so that we can link it to the respective authorization to pay those benefits. In the out-of-hospital setting, that requirement has been removed. You can see invalid ICD-10 code. Generally, when the ICDs are not coded to the level of specificity that it requires, it would be rejected, or if there's a mismatch between the claim and the auth. Motivation required. This generally applies for sessions, more than one session performed per day, and we do see it where there's individual and group sessions that may not necessarily be authed for, that this will then apply, and fully specified accounts required. As much as that is significantly low, what we do tend to see from time to time is that some practitioners submit handwritten sort of invoices, not always legible for us to be able to determine, ICD-10 code, procedure code, or even patient details. This next slide, I indicated one of the rejections is as a result of referring provider not captured on the claim. What we also do from an in-hospital perspective is do check to see if the referring provider is captured and who the referring provider is that's captured. So this slide, I won't go into too much detail, but graph 1 on the left is in-hospital and out-of-hospital experience where patients were referred by a psychologist or psychiatrist, and a particular interest or reference here to mental health, because we do find in instances, and if you look at the graph 2, you can see that mental health referrals, the ICD-10 that are psych versus other sort of disciplines that is indicated there on that particular graph. So if it is a mental health admission, especially in the in-hospital setting, the expectation is that the referral would either come from the psychologist or psychiatrist, but we do see that other disciplines are also included on your referrals when you submit the claims. And you can see the experience there across the in and out of hospital spaces. My next slide is just also giving an indication of the top 4 referring disciplines that we see that are not necessarily psych related for both in and out of hospital. Of course, with GPs being also the top referrers, we do understand that GPs may refer patients, to the social worker practitioner. And so this is what we see both in and out of hospital, where it's not psych related. If we move to the next slide. This is giving trends and comments for social workers. And this particular slide really is looking at billing rules that we implement from time to time as a risk mitigation, especially where we do observe that claims are being received, multiple tariff codes are being billed that are not necessarily allowed to be billed together. So there are billing rules that are in place, and this is just the view of the 2025 experience. The largest rejection category does relate to claims submitted without a referring practice. And as I indicated, in the in-hospital setting, it is a requirement. It is no longer a requirement in the out-of-hospital setting. The ICD-10 rule restrictions account for 4.35 million of the claimed amount, of which approximately 3.7 million was paid following validation. And then tariff combination rules, 2.16 million there of a claimed amount, of which a very small portion is then funded after review and if additional clinical information is required. So the next few slides are a few fraud, waste, and abuse and now error. So these are insights that have been shared by our claims risk team. They are responsible for managing fraud, waste, abuse, and error on behalf of the scheme. And what we see from a mental health claims trend perspective is that the mental health expenditure is on the increase. And I think as I shared in the previous slides, and we see this both across facilities and community-based care. So there is an indication that the utilization and trends are increasing. And it does, to some degree, is explained by growth. However, to a lesser degree, the overutilization still remains somewhat unexplained. And the patterns really raise concerns regarding efficiency and appropriateness. But we also see PMB funding requirements may contribute to extensive utilization. Care coordination does appear to be fragmented in some cases where there may be multidisciplinary teams, and you'll see in a case study that I will share a little later what we mean when we say care coordination appears to be fragmented, where a single member may be visited by multiple practitioners within one day of treatment, sometimes exceeding, the expected number of hours that you would expect a patient to be receiving treatment in a mental health facility. If we also look at the current tariff structures, they are largely time-based, and we see in certain instances that these time-based codes are billed predominantly by our service providers or practitioners over and above the lesser time codes. If I move to my next slide. So this is just a practice level, view that we're sharing. And you can see these are facilities. And here we've listed the top 10 facilities just to demonstrate the increases that we are seeing in utilization. There are several concerning patterns that have emerged through claims analysis, but also through provider interviews, where some practices do appear to claim for treatment times beyond what a single practitioner could realistically provide. Clinical records frequently lack session duration details that are necessary to validate billing. And the use of locums also presents verification challenges due to incomplete documentation and inconsistent staffing records that are kept. And then virtual consultations have increased as well. Often supported by limited documentation. Additional tariff codes are sometimes added to increase the claims values. And these findings really do suggest a need for stronger validation controls and enhanced provider oversight. Of the top 10 facilities that we've listed here, what we are demonstrating is the benefit that we paid to other disciplines outside of the actual facility. And you can see facility 1 to facility 10, although facility 10's overall cost is significantly lower, you can still see the increase in benefit paid is, a lot higher than would be expected. And in terms of the expected disciplines paid, so we would take a facility and we compare to other facilities providing the same services. We would look at all the other related disciplines that participate in that particular event, and that would bring us to what we say expected other discipline paid. So you'll see there in the third column, if we're looking at facility 1, that particular other disciplines expenditure was 51 million. However, the expected disciplines expenditure was 23.2 million, and you can see it's in excess by 120% at 27.8 million. I'm not going to go through each line, but I think, the principle is clear on what we are seeing in the claims data from a facility as well as other associated providers claiming against that event. This next slide is I'll go into the case study, just showing it to you in the next slide, but I think this does demonstrate an example where solo practices are claiming time beyond the capability of a single practitioner. And therefore, there could be an element of either other associates, locums, etc. Also, perhaps the practices are providing services at wellness days. But when we look at their claims experience, it does appear to be in excess of what would be expected, especially in terms of the time codes that are billed on a particular date by a particular practitioner. Clinical notes, as I indicated, in some instances do not record any start and end time, to demonstrate the duration of sessions billed. Locums work part-time in practices, either state employed or have their own practices or working at other practices. So verifying staff does become a bit of a challenge. And paucity of records really to verify which patients were seen by the locums or the time spent with the patients, as there's no contractual agreements that are often in place when these are requested. Also indicated on the previous slide, where we are seeing escalation in virtual consults with distant patients across provinces, things like WhatsApp calls, referred by work colleagues, etc. And 90% of claims are attributed to these type of services for some practices. And when you request documentation, there's no clear documentation to validate the services. And then additional or inappropriate tariff codes and time claimed, as I indicated, is exaggerated and used to cover costs such as travel, locum fees, cashbacks, etc. I'm not going to go through this particular slide, but it will be shared with the colleagues. But these are just some additional concerns raised around who gets to participate in the mental health sort of events, and if the psychiatrists are, to be in control of who participates in those events. Because when you look at, practice records and referral practice, it doesn't always correlate, and there does appear to be a lack of coordination amongst the therapeutic disciplines or the multidisciplinary teams in these facilities. Perhaps I'll just also note what we do see, and this is not in your particular discipline, but it's just the trends from a mental health perspective, that you'll get one practice billing over 1 million per month in a single facility, unbeknown to us when we look at the claims data, that the practice does have multiple locums, servicing the practice because they're registered as an individual practice. But this is only then it becomes evident as we do these investigations. So this is the case study that I referred to, and you can see in this case study, it really is one member that was seen on the 15th of May, 2025, and the member was consulted by a psychiatrist an OT, a psychologist, physiotherapist, dietitian, seen again by an OT, and then subsequently a social worker. And if you collate all the services or the treatment time-based codes, it means that the patient would have been consulted for more than 8 hours in that particular day, and just 1 day's worth of claims amounting to approximately 7,600 Rand. And so, collectively, as I indicated with the multidisciplinary teams, the question that is then asked is the validity of some of the claims. And unless you put the picture together, you really can't see the fact that the patient was consulted for extensive, number of hours within a given day. And it's pictures like this that then warrant further analysis and engagement with providers. But I think that brings me to the end of my presentation. And perhaps as I step down, it's really just to share with the colleagues from a claims, cost and utilization perspective what we are seeing, and that we are noting mental health being a particular or primary driver of claims, cost and utilization, the longer duration tariff codes being billed, and issues around the referral patterns, specifically in the in-hospital space. Thank you.
Thank you, Ms. Mbuto, for that wonderful overview. I'd now like us to move to the Q&A session. We have received a number of questions, and I'm also seeing the hands raised. But based off the questions, I am seeing a mix of technical questions and some important concerns coming through. And I do acknowledge the participations as well as the acknowledgement we are receiving from our colleagues. So the main themes really are around our referral requirements that I'm seeing. I'm also seeing the questions around out-of-hospital services. There are issues regarding claim rejections and some system-related issues which we will help you with. Documentation requirements is also part of the themes that we are picking up. So for Chantel, before we move over to the hands, what is required for correct claiming, and how do we process this, as well as what documentation would you need in order for us to align to your requirements as well as our professional obligations, please? So it's just a theme question around what we've picked up. I know you have emphasized on this, but for those who have missed it, what would be the requirement from a claims perspective, and what do us as healthcare professionals need to do in order to oblige to these processes?
Thank you, Chloe. I thought you'd give me a moment to catch my breath, but I'm going to attempt to answer the question. I think from a claims perspective, the first and most important thing is what we call a valid claim. So a claim should have a membership number. It should include the patient, either detailed date of birth or dependent code, a valid ICD-10 code, a valid tariff code, as well as the practitioner's details or practice number, etc. Date of service is also part of the, I think, high level claims validation criteria. Once that is then populated and submitted, as the claims administrator, we will check if that member has benefits available. So in the out-of-hospital setting, members do have what we call limits and sublimits per option. Some of those limits are what we call shared limits, and it would apply either to a beneficiary, so there may be a per beneficiary benefit limit, or a per family benefit limit. If it is a per family benefit limit, it is a shared benefit limit. So if the claim does meet the requirements, we would then, as I indicated, check if there are benefit limits available, and if benefit limits are available, we would then proceed to pay the claim. That being said, as I indicated in one of my prior slides, that we do implement things like clinical and billing rules, and as an example, tariff combination. So you may not be able to bill a tariff with another tariff. And generally, we see that as one of the drivers of rejections. However, that being said, the provider has every opportunity to provide additional clinical information or motivation that is reviewed by the medical advisor. And if there is clinical merit, the claim can be reviewed and reprocessed. So I'm hoping I somewhat answered the question, but happy to circle back if not. Thank you, Chloe.
Thank you, Chantal. We'll go over to our managed care processes, Dr. Makaba and Itu. So the themes that are also coming through here are regarding our clinical requirements, particularly regarding GP referrals or other discipline referrals, as well as documentation that is required. We've also received questions around maintaining confidentiality. I know that you have addressed this as well, but where it particularly comes to referrals that we require for the discipline of social workers, the documentation that we would like for them to send for us to enable us to approve and authorize treatment required, and concerns around confidentiality. How do we manage this, and what feedback can we provide to our attendees today in regards to that? So also trying to stick to our time frame. We do want to end the session at 6 o'clock, but the recurring themes on the chat are regarding referrals, documentation that is required, and the concerns that we are getting from professionals, as well as with regards to confidentiality. So I would just like us to summarize those concerns and maybe just address them. And Itu, I'd like to start off with you, and you can hand over to Dr. Ziyanda, if you'd like to, have her clarify further some of the questions we have received. Thank you.
Thanks, Chloe. So maybe let's start off with the issue around confidentiality. Sorry, can you hear me? I know earlier my sound. All right, perfect.
Yes.
Thanks. So I know earlier Dr. Ziyanda did touch on it, but maybe just to provide comfort for everyone. So we are not saying go against your different councils, right? We are not saying you need to breach confidentiality. We are saying you need to give us enough information to make a funding decision. And it's so important, maybe to put it that way, because I know some providers do feel as though, by giving us the information, they are breaching that confidentiality. No, that's not what we are saying. We are saying, give us information to make a funding decision. As a funder, we need to know the type of care that's been rendered, right, to the particular member. And if we don't know what's been rendered, it's going to be so difficult for us to actually make a funding decision. And that's why you need to work within, the bounds of the different councils that you have. I know also Dr. Ziyanda touched on the issue of, I know we can ask for clinical information, but we're not saying breach, confidentiality. That's one. I see in the chat, there may be confusion around the referral letter. So I was speaking about the in-hospital process, right? That's where you would require a referral letter. So if patient is in hospital, the treating doctor, so I'm going to say either the psychiatrist or the doctor that's actually registered on our particular system. In some instances, I know in rural would be the GP. In hospital, that's who we want the referral from. Out of hospital, that's a different process. This is not applicable for that. So it's in hospital where you would require the referral. And it needs to be from your treating provider that is loaded on our system. So it'll be your psychiatrist, and obviously in some instances, maybe a GP, depending on the region you stay in. Thanks.
Dr. Ziyanda, in regards to the documentation, what are some of the challenges we get in terms of documentation required and how we're managing that?
Thank you, Chloe. I think the best person to answer that would have been Itu. I thought I was going to speak on the on the regulatory bodies, but I'll attempt and hand back to Itu. So some of the documentation issues we get is that we will get a request without the referral letter. But not only that, we would then have at least in this case, a social worker having a referral letter, but almost as if the professional is referring to themselves. So it will be in the social worker's letterhead or template, but then referring the patient to that social worker, which obviously wouldn't be, if it's a referral, it would be from the primary treating provider, which in this case could be the doctor or the specialist, to the social worker saying, I've got this member who needs to be seen for XYZ, please offer the services. So I think some of the biggest concern would then be on the incorrect, if I can put it, a referral template where someone is self-referring a member. I think those are the main concerns as well. So rather it should be from the primary provider. Thank you.
Of course. And before I hand over to a raised hand, I think we just want to also get clarity regarding the out-of-hospital services. Are these provided for social workers as a discipline? Can they see members in an out-of-hospital basis? And I'll hand over to Inwan for clarity on that.
Thanks, Chloe. I'm happy to take it. So out-of-hospital services are indeed funded for by GEMS. As I indicated, there are sublimits that would apply for each option, and those would be available on the GEMS website under the GEMS scheme rules. So you can see, based on the member option, what the annual limit is for social worker services. As I indicated, it is a shared sub-limit with other disciplines. So based on the benefit available, of course, the claims would then be funded accordingly. Thank you.
Thank you. And I hope that provides clarity to everyone. We saw that as a recurring theme today. I am now going to move over to Gitumedzi. Gitumedzi, you can unmute yourself and ask your question. Is Gitumedzi unmuted? You can go ahead and ask your question, Gitumedzi.
Hello.
Okay. All right. Go ahead, Bakane. You can go ahead and ask your question.
Yeah, no, thank you very much, Chloe, colleague. My name is Chilizi Colin Bakane, the social worker who's working at mental health services in Lekhaye Mediclinic. Ne? Yeah, first of all, I would like to appreciate the map that was given to us. And I would also want to confirm to say I am one of the social workers that is utilizing it so well. But the frustration part that is coming from my side is in two areas. Number one is the delay after having sent the referral letter from the psychiatrist or the psychologist with a treatment plan. And what I've identified as a challenge is that, number one, you'll find that when you refer through a treatment plan, the clinical department will come back to say, give us a LOS. When you do that, they will come back to say, we have referred your matter to the clinical evaluation or team. When you do that, when you send the progress report, they will even go in as much as saying or indicating that they now request for a progress report. So I think with those, for me, is a major concern because we end up servicing a lot of GEMS clients for free, and that is an area of concern for me. Like even now, as I'm speaking to you, I'm still in the office servicing about 10 to 14 GEMS clients because they are the ones that we are seeing. So I think GEMS would also need to attend to that as well, because we as service providers, we even ending up, running at a serious loss. And the other challenge that we are also experiencing, as social workers, when the psychiatrists are referring to us, a number of cases, we are the profession that is supposed to be solving almost all the challenges that the patient are presenting with. For an example, you find that we also need to do work visit, like the consultations, family sessions that we are conducting on Sundays and issues like that. But when we try to get authorization, the delays from GEMS, to be honest with you, I just felt like you raise a lot of red tape, because from where I'm sitting, I think when you try to refer this or when you try to submit this so that you comply with what we have said, then the clinical team can still come back and say something else. I think even from the group where I belong with social workers in private practice, that is our major concern when it comes to GEMS at the moment. And again, for me, I think when you are trying to clarify clinical notes and confidentiality, the two for me clashes, because when you say clinical notes, that for me suggests that you want a detailed information, even though it can be limited, so that you have an overview of what is happening. So I think there is a serious violation of POPI Act in as far as my view are concerned. And the last thing, you also indicated limits while patients are admitted, or authorization or practice or healthcare professionals not allowed for treatment. That for me as well, I also think that GEMS is doing that unfairly, because you still say that when you are rejecting a claim, even though the above have been admitted. Yeah, so I think for now I'll leave it at that point so that we get you to respond to the question that I've posed. And the other challenge that I've also identified in this webinar is that if you say you are going to make a cut-off at 6 and we started at 4, the majority is that GEMS officials were the ones that were talking. So it means that we as social workers in private practice, we are not afforded an equal opportunity to respond and to also raise our concerns. But I think for now, I will stop here so that my colleagues will also add their experiences that they might be going through at their different respective offices. Thank you very much.
Thank you, Colin. I think just to summarize, I think you are when you want to address the issues around better support for social workers and for us to at least improve consistencies as well as prevent delays. We do have a couple of hands, but
hello.
Yeah, hang on, Bongiwe.
Okay.
Yeah, so you can mute yourself so long. I would just like to hand over to our scheme colleague, Dr. Siviwe Mila, to address some of your questions as well as concerns that have been raised on the chat. And further to that, we'll hand over to our managed care team, Itumeleng and Dr. Zianda. But handing over to you, Dr. Mila, to assist with some of the concerns as well as where we are as a scheme in in consideration of the points that have been raised in today's discussion. Thank you, Dr. Siviwe.
Thank you so much, Chloe, and good evening, colleagues. Apologies, my camera is not functioning. But I just wanted to maybe answer quickly the last social worker that was stating, the elements of discomfort and where they believe we can improve as a scheme. I think it's important to note that as a scheme, we are committed to making sure that our members get treated, and we understand mental health is one of the biggest issues that we're contending with, and not just as GEMS, but in its entirety, even in the world, and not only a South African thing. So that's one footing that we can say we are aligned. And two, we are not wanting to cut benefits or not help our people. I think that's one thing that we must also be stated. And this is another platform of numerous engagements that has been happening, especially with social workers. As far back as in January. I joined the meeting a bit late because I was in another engagement, but I think, it would have been mentioned in the opening. And the important part is to note that right now, with the position of the scheme is, how do we work all together? Social workers, psychologists, physios, OT, psychiatrists, how do we work better to make sure our mental health care users are better managed and also appropriately managed? So when we're talking about the element of the HPCSA and also the SACSSP, one of the difficulties about social work is that they do have a different regulatory body. And in that also there are some improvements ideally that the regulation body should have, and we have had engagements with them. So a couple of weeks ago, we had a meeting. Social workers were in the room, psychiatrists were in the room, SACSSP was in the room, and also academia representing social workers were in the room. And there is a task team, specifically the one that I'm leading is on the scope of practice. Because what we are seeing is the same person, as you're seeing people on Sunday. A person gets admitted for 21 days. For the 18 days there, the social worker is seeing the patient for maybe an hour to 2 hours. The psychologist also seeing the same patient. And some of the social workers are claiming for procedures they should not be doing, psychotherapy, and they're not even showing us, the qualifications of doing psychotherapy within South Africa because it's a very specialized field. So as much as you do have your concerns, we also have our concerns, especially when you look at clinical evidence-based medicine and what is the way of practicing. The other challenge that came up in those talks were that the psychiatrists are the ones that are admitting, but they will have social workers or other disciplines treating their patients, but they've got no knowledge of what they're treating them for and what those sessions involve. So I think it's best to say, Chloe and the colleagues, that there is intensive conversation that's happening. There are also elements of frameworks that we're going to come up with, that how do we better function together in this ecosystem, because we cannot look at mental health like it is, because it's almost like everybody wants a piece of the pie, and the person who grabs the sticker first is the one to claim first and gets the money first. But it's not looking at what value are we getting for the patient at the end of the day, and what does it translate to. So I think I just wanted to make those clarifications, and we will be able to come back and report back in terms of what the inquirers have looked into. It will look into elements of academia and look into also the element of your regulatory body in conjunction with what the HPCSA say, because we also have to be the custodian of the beneficiary in terms of the patients to also look out, are we doing the best and giving them the best care? Thank you.
Thank you, Dr. Sviwe. Appreciate that. Idu, some concerns that have been reiterated and that we keep hearing of about escalation processes. How do we support our healthcare providers in light of the delays that they are experiencing, especially where their members have been admitted in hospital?
Thanks, Chloe. So I'm going to, before I answer that, I think I do want to just speak about, I think one of the things that we've spoken about earlier was around the treatment plan, that we asked for a treatment plan, and then we say it's gone to Caseman, and then we ask for a progress report. And I think it's also just important to note, when I started speaking, I did not speak about a treatment plan. So part of that reason was because that's where I think a lot of providers or practitioners were having concerns. So because a treatment plan is right before you actually see the patient, that's where the information was very limited. And because then the team is not able to make a decision for the 21 days, because it's such limited information we need to actually understand. That's why for today's meeting, I said your progress report. Part of that is because with the treatment plans, I think that's where we saw a lot of one-liners, where we would say first consultation or onboarding, financial management. So we were not able to make a decision. And that's why in today's meeting, I mentioned that we have been trying to improve the process. We are speaking to providers, and this is why now the messaging today does not include a treatment plan. So we will be sharing updated comms with you to say a treatment plan, yes, you can share, but we are not able to make a funding decision for the full period that you're actually looking for, because we require additional clinical information. And then once we have then received that treatment plan, sorry, not treatment plan, progress report, we send it then to our case managers. The case managers would then make a funding decision based on the information that they have. And when you get feedback that says it's gone through to the case manager, it just simply means that the team is accepting what you have submitted so far, and they are sending it to the next level for someone to make a clinical decision. And that's the feedback. So you should get feedback within a few days thereafter. And then the last bit, you spoke about the escalations or the submission. So the inquiries email address has always been our go-to channel. So we introduced the hospital auths process to try circumvent, obviously, the long wait time, because a lot of providers are complaining that the inquiries email, the 10 to 15 days is too long. That's why we then said hospital auths if patient is in hospital. Further to that, we have introduced the escalation process. So that email address that I shared earlier, I think most people are seeing it for the first time. And that's where we are trying to make sure that we are getting some of the concerns and some of the queries. And I think that's why we implemented the escalation process, so that if there is a delay, because as fund management, we monitor the number of queries that actually go there, because it would tell us that our process is not working. And that's why it's so important for us for providers to use the correct escalation process if the normal process has failed. Thanks.
Thank you, Itu. Lauren, you have your hand up. You can go ahead and raise a question, please. Lauren Smith.
Hi. So I just wanted to bring some context into the conversation. So not all of us are mental health social workers. Some of us work in palliative care and oncology, and then in a counseling setting. Myself, working in an acute setting, my role a lot of the times is to ultimately save the scheme funds by getting the members out of hospital. We normally see this trend happening in November, December, where the scheme actually becomes a frail care benefit for some families, obviously inappropriately so. And my challenge that I had, I'm in private practice now for 12 years, is my letters of motivation, letters of referral, all of that go through to the scheme. And we get a feedback, and we don't even send a claim without myself writing a letter of motivation and then the referring specialist sending a referral letter. Every single time a claim is done, it is said discipline not allowed. So my question to James is, so what is your idea of a social worker in the acute setting? Because ultimately, if we're getting the patients out safely, we are saving you funds and preventing readmissions for inappropriate admissions. So number one is, what do you see our role in the acute setting? And obviously it's all time-based. I understand all of those clinical note keepings, no problem. I don't have a problem with that. Then the second question I have is the use of locums. And this is something we have discussed within the SASWIP structure. SASWIP is the social workers in private practice that should ultimately be involved in negotiations with medical schemes on behalf of South African social workers, because they started the regulatory bodies for social workers in private practice. And when we talk about a locum, I'm not talking about a practice billing 32,000 hours per year and using 10 locums, because that should definitely be a group structure, right? I'm talking about, say now myself, that has unforeseen circumstance and I need to have a locum stand in with me for 5 days. I obviously have to pay that locum, but what is the requirements for if, say now, your fraud usage contacts me and says, Lauren, instead of billing 2 patients a day, you're suddenly seeing 7, which would be like that, then I need to be able to produce documentation, like a locum agreement, their BHF certificates, their malpractice insurances, and their social work certificates. But is there any sort of guideline you have regarding locums? And then just as a third side note, the clinical speciality of social workers, which I'm not one, has been recognized by the South African Council of Social Service Professions. So there is a drive at the moment to have social workers register that specialization with our council. So that will just assist James in understanding more, who of the social workers can actually be doing PMB applications and who can do psychotherapy, because clinical social workers are psychotherapists. So that's just a side note for everybody on the evenings joining us. But yeah, clinical setting, acute, and then secondly, what is your requirements for us to have on record to utilize a locum? Thank you.
Thanks, Lauren. We have one of our senior managers as a panelist as well. Mr. Ramuelo, are you able to assist in regards to the conversations that are currently taking place with the task force team involved in these alignment discussions for social workers?
Thanks, Chloe. I think there are three questions there. So I'll request maybe Dr. Ziyanda and you to speak on the first one, and then I'll speak to the second one. The third one, I think Dr. Miller can also chip in there in terms of the task team. I think she did cover that aspect. But let me go back to the second question. I'm not aware of any guideline in place, but in our case, when there is any work being done to look at the claims utilization experience of a practice, if there is anything that perhaps may require some discussions from a GEMS perspective, following some of the Section 59 era, we have changed some of our processes where we will also engage you as a practice before being labeled as being fraudulent or wasteful, in order to understand, what we are seeing. Remember, from our end, it's data, but the one who is sending us the data can tell a story about what we are seeing. So we have that opportunity. We have exercised that to engage practices. And I'm sure some colleagues on this call, maybe some of them have been engaged in the past. It's a very a cordial process, but no one is labeled upfront. We don't do that at GEMS. We first have to sit down, engage you, and understand what is happening behind the data that we are seeing. And based on the information that you provide, we are then able to move forward to either say we understand, and then we remove that aspersion, if I may use the word, or accusation. So we don't do that at GEMS, unless if any of the colleagues on the call can say otherwise. I'm comfortable with that response. Dr. Miller, on the third one, before maybe I hand over to Dr. Ziyanda.
Thank you so much, Mr. Ramuelo. So I think Lauren, I did speak to the element of engaging your body. So right now, just a practical example, if you go on the HPCSA website and you put in my MP number, you will find that I am an independent practitioner where qualified. And when I became an independent practitioner, if I've got any specialization, you're going to see that. But you, as social workers, don't have that platform. If you go on the SACSPP website and put in a practice number or a person social worker number, nothing comes up. And that is the issue that we have been raising with them. So if you're saying that there's work that has been done, because with the psychotherapy, remember you've got auxiliary social workers, you've got clinical social workers. And within clinical social workers, they have to have a certain speciality or certain accreditation for them to practice psychotherapy. So there is no way right now that is known to us as the scheme. And we did an intensive investigation, even with BHF, that it recognizes, like a specialist, you would say that's a psychiatrist and you're able to see that at BHF. But currently, to my knowledge, there is no platform that you can go into and find that out. If you do have that, it would be great. And as stated, that we are looking at the scope of practice when it looks into the mental health. And then maybe just to answer that part, I know that the MCO will come in specifically for this exercises rather. We are looking and zooming in on mental health. We're definitely not discarding the work that happens in acute and the palliative sector, but our biggest burning point right now is to how do we come together around the table in a multidisciplinary approach when it comes to mental health. And we believe that the insights that we're going to get from this exercise in mental health will be able to be used across all areas, be it palliative, be it oncology, be it also in the other extremes, or maybe rehabilitation spaces. But I think for these webinars that we have been putting together, it has been specifically zooming into mental health. We are not saying the others are not important. We're just saying we are starting with this one. And the learnings that we take from here will be so easily implemented on the others. So if you can, I'll share an email address on the chat. That information that you alluded to towards the end, if you guys have got that, please send it to us, because we have been on the lookout and we've raised this even with a regulatory body, that it is a thing. Even SASWIP was also in that engagement, that it is a gap that needs to be filled, because right now it's difficult to see what else needs to be done in that specific sector. Thank you.
Wonderful. Thank you, Dr. Miller. Lauren, just in the interest of time, we have noted your questions, and we will be consolidating all the questions as well as recreating an FAQ for all practitioners on the line, and we will share the answers to your questions accordingly. We'll also be providing an email, as Dr. Miller has pointed out, and further queries as well as questions related to your memberships and your clinical practice can be directed to that email address. EDU has also shared an email address that we have recently created, which is the hospital auths at GEMS. And for that email address specifically, you can also address some of your claims that have been unpaid. I'd now like to move over to John Marie. John, over to you. You can unmute as well as raise your question. Thank you.
Hello, can you hear me? I hope you can
Yes,
hear
I
me.
can. Thank you.
Okay, so thank you for taking my question or my statement, my frustration sometimes. But I first of all want to thank GEMS for allowing this form of communication. And social workers are big on communication and trying to understand our social environment that we work in, and specifically also the environment that our patients live in. And I think it's really important that you get to understand what we do and what we do for our patients, because it's complicated. And we have a specific input in the multi-professional team. And also certain social workers have got different types of specialities and knowledge. We are not all equally qualified and equally experienced and equally skilled. So in some multi-professional teams, some social workers will be referred to more for services rendered because of these specific skills or their specific knowledge. And I think that must also be taken into consideration. I really value this forum where we can discuss and talk about things. And we value SASWIP, our association that speaks for the social workers in private practice. My one frustration that I have is that the goalposts are always changing. And the moment that we have a certain system, that we do things, the next moment, the next email I receive, the next comment I get from GEMS on the letters that they sent back when requesting authorization or update of authorization date, there's another thing. There's always something else. And that is very frustrating. You need to understand that my responsibility is towards my patients and getting them back better as quick as possible, even though 21 days in hospital is what they are entitled to for PMB mental health. I'm trying to do it as fast as possible, but some of these cases really take time. But then we have to do all these administrative tasks. And with the goalpost always changing, the escalation processes, what they want in the process notes, or the fact that these things all is changing all the time is really taking time. I mean, sometimes for the same type of authorization or situation or clinical indication, I will send in information over, and then I get different responses within the same week of the same type of situation from GEMS. And that for me is confusing. And then sometimes I get authorization for a Sunday. I don't see patients on Sundays because I know that GEMS does not allow Saturday and Sunday treatments. But like my colleague said, sometimes that's actually what you need to do because of family members wanting to come in or they're only able to come in at that time. And the other day I had a comment from James where specifically the doctor asked a patient to be seen by the psychologist for certain goals and certain treatment indications, and me for others because of the fact that the family dysfunction is really maintaining the patient's psychiatric condition. So in my treatment plan, I indicated that amongst other treatment modalities, I used CBT. Now, to get back from James, how can you use use the same CBD modality because the psychologist used it? But I mean, that's ridiculous because that is a modality that you can use in group therapy, in individual therapy, in family therapy. And for me, it's a bit overstepping. James is there overstepping their boundaries of what they know, of what I can do and what I'm supposed to do. And I don't feel respected by a comment like that. Yeah, and so that's more for me the big issue. And sometimes I send things through, it takes weeks, it takes months for authorization. And this is frustrating and it causes resentment. I mean, there was a stage now for the past few months where psychiatrists referred patients to me for urgent attention. And when it's a GEMS patient, I would say, sorry, I'm not going to make time for this patient because I don't have the time for sitting in front of my computer, sending email after email, progress report after progress report, complaints to this department, that department. And in the end of the day, this is not in the best interest of the patient.
Thanks, John Marie. Thank you so much. We've noted your concerns around specific patterns as well as consistencies. Standardization has also been one of them, and we hear all of you. Thank you for representing the healthcare professionals today. We'll move over to the next hand. Lifa Marule, your question, please.
Hi, can you guys hear me?
Yes, we can, Lifa.
Hello.
Go ahead.
Hi, I'm just sorry, I just wanted to add to what Jean Marie was currently saying right now from the billing perspective. So if a client is being referred to the social worker and the client has been admitted in the hospital for the first 5 days, the admitting doctor decides to refer the client on day 10. We submit the referral letters and we request for an authorization to be uploaded. Why is it that the authorization is being uploaded from the day of admission and not from the day the client is being seen by the social worker? And also just to get clarity as to how long it will take for the LI department to actually update that authorization for the correct dates that we are requesting for. Because I know that previously, last year, for instance, if we submitted the referral letters, we were told that no, in order for the claim to be paid, we need to submit the claim first, submit the referral letters, and have them escalated with the specific service dates the social worker is consulting the client on in order for the authorization to be linked for those specific dates. This year, that has changed. Now you guys are uploading the authorizations from the date of admission and not from the day the social worker is seeing the client in hospital. And then a second query which I wanted to actually bring up with is that with the new emails that you guys are giving us now to refer the referral letters and the progress letters and stuff, who do we speak to in the event that the turnaround time has elapsed and we still have not yet received an authorization or outcome via email from the medical aid? Because whenever we do call the GEMS line and we speak to the consultants, I'm not being harsh, or I'm sorry if I am coming across as being harsh, but those consultants are clueless because they really do not know what it is they're doing. The only thing they would tell us is that, no, it's been escalated. I'm referring to claims that have been, repeatedly being escalated for more than 12 months without an outcome. And whenever you do ask them, they just tell you like, no, it's with the allied department. They're not giving us any answers whatsoever. And lastly, sorry, what was the last question I wanted to ask? Sure. Yeah, I think that's that for now. Sorry.
Okay. Thank you, Lefa. So we've heard and noted your concerns around our escalation channels, some inconsistencies in line with that. We would like to encourage you to consolidate in a spreadsheet format all the queries that you have. The servicing lines as well as escalation channels have been provided to you, and you now have our details. You know who to ask for in the event that you go through to call center and no one is able to assist you. So we are here to improve our collaboration and support for you as a discipline. I'd now like to take Patient's hand, and this is because we do have a very hard stop at 6 o'clock, but I think I'll open the line till 5:06. Patience, go ahead. Thank you, Lefa. Patience?
Hi, can you hear me?
Yes, we can. Go ahead. Just a brief point from you.
Okay. All right. So thank you so much for the platform. I just want to reiterate on the question that I've written on the chat because I work at a rehabilitation center for substance abuse. I want to know if at all it is possible that once the rehab has submitted their claim, can I also, as a social worker, submit my own claims for individual and group sessions separately?
Chantal, just a quick one on that. Individual sessions, individual claims for individual sessions. And these are not group sessions, Patients. Is that what you're implying?
No, I've done both individual sessions as well as group sessions with clients who are currently admitted in a rehabilitation center for substance abuse.
Okay. Chantal, just a quick guide on that.
Thank you, Chloe. If it's in the in-hospital setting, it will first require authorization. And based on the authorization, then those claims are allowed. We do see claims from social workers for individual and group sessions, but it is based on the authorization and the treatment plan that is provided. Thanks.
Thank you. And once again, the escalations channels are available for us to update your authorizations, dates that you have seen your patients, and so forth. Catherine, you would be our last hand for the day. I apologize to anyone whose hand is not going to be provided a chance today. But like I said, we are going to be having an FAQ document to be sharing with you. It will be addressing all the questions we have received today, as well as the servicing channels that you have asked us to provide to you. Catherine, your hand is up and you can go ahead and raise your question. Catherine is muted. Tembisa, you can raise your question. I can see that Catherine's mic is muted. So Tembisa, go ahead and ask your question.
My name is Tembisa Oyo, and I work in a psychiatric environment. There's something that is confusing to me. Here, patients are referred to the social workers, when they on their admission. In many instances, the social worker has had no prior therapeutic relationships with the patient, and social worker has got no background information available at the time of the referral. And now social worker is expected to rapidly establish a rapport and conduct a comprehensive psychosocial assessment, identify these immediate risks, understand family and social circumstances. Now, my question here is that how do I first submit a treatment plan before I see the patient? That's my question. Thank you so much.
Thanks. We heard you. Catherine, do you have a question before we close off? We heard your questions, Thembisa. Catherine, you can go ahead. Vuyokazi, in the interest of time, would you like to ask a question? I can see that everyone's mic is muted, but Tembeka, do you have a thought? Our last question, we'll take your last question and try to get a concise answer and brief answer. Okay. Tembeka?
Hi. Can you hear me?
Yes, go ahead, please.
Oh, thank you so much. Firstly, I would like to first acknowledge and appreciate this platform because it has been very, very challenging for us for the past months, because one thing that has been clear was that we were trying to actually understand the process, and we were faced with challenges on GEMS side as well, where majority of our concerns were not actually cleared up. On my side, I feel that maybe this very same approach, it's something that needs to be communicated with your first line consultants, because those are the people that usually engage with us, and in most cases they are clueless, so they don't actually give us the specific directions as you guys are doing right now. One thing that I would like you to maybe consider on our side, the social work side, one thing that has actually been one of my major frustration is that that discipline is not understood. And when we are not understood, then it becomes even harder to actually give you what you want from us, when you don't actually really understand what is our core function as social work, be it in every field that we are currently working in. And number two, one of another frustration that we have on our side, this admin is taking a lot of time. This admin is demanding that we work extra hours. For instance, we value the work that we do, but obviously there should be value for money as well. For instance, the rate for a group session and the admin that is required thereafter, it doesn't really talk to each other. And I think the most important thing that I would really request that at least be inconsiderate of, we are trying to make work a bit manageable on our side. And there are new systems that keep on being improved to make work a bit, manageable. But we're finding ourselves back with so much admin that is required from GEMS side. And one thing, I've tried both processes, the prospective as well as the retrospective. And believe me, the time frames as well as, the time required for us just to do the follow-up, that would demand that I can only work 4 hours, and the rest of the hours I'm doing the admin as well as the following up on it. So if it's possible, if you could consider making it so sufficient and making it so easy on both sides your side as well as our side. We really, really appreciate that platform. We really appreciate actually having to use these services, being private, and also having to actually assist people in that manner that we do. But one thing that really, really, really stresses me is that I feel we are not actually given a platform where we are known who we are, because as we are engaging, it still comes across that no, we are surely not understood in this field. And it is important that you understand what the function of a social worker is, so that you don't request things that does not really talk to us or talk to our processes. Because there's an intake, there's a lot that take place before I can actually say, this is what I'm going to be treating from this. And for me to get to a point of a treatment plan, that would mean that I've set at least 5 sessions with the patient. Thank you so much. Hello?
Good afternoon once again, colleagues. I don't know what happened to the chair, but the part that I'm stepping in now is purely to thank everyone for the time that we had this afternoon. We must state to everyone that this discussion for this afternoon is not the very first and the last one. We will be preparing another session, more of us even giving feedback to everyone, hopefully before the end of October this year. So please be on the lookout for another session where we will be giving feedback. And for some of you, before that time, a GEMS colleague would have come or requested to have a session with you either virtually to assist you as well. Now, just at a high level, we have heard the concerns around the understanding of social work. And as indicated by Dr. Miller, we are working very closely with the regulatory body, as well as SASWIP and other groupings that are representing social workers. So we've met with them, and it's a continuing work. And then we also have regular engagements with SASWIP ourselves. We will be having another one very soon. In fact, they have been very instrumental in assisting us to distributing the invites as well. So we have that good relationship. And it is in those engagements that we get to understand you better. The second part is around the administrative burden that you have raised. We've taken note of that. And as colleagues also indicated earlier, there is a work that is being done towards a template that will assist with alleviating some of these challenges. And also the issues around the contact centers that we have with the first line agents, the challenges that we're experiencing with how they are assisting you when you call in for various matters. We are looking into that as well. And I'm hoping that when we meet before end of October, you will be telling us a different story in terms of these challenges. And I must say that we really appreciate the cordial way in which this engagement has taken place. We have taken a lot of the inputs that we have given. And what we are going to do, we are going to take all those questions that you have asked us. There's almost over 220 questions that we have received. And we are going to package them into a Q&A document that you will all receive. So some of the questions we have not yet responded to because of time, as we are also trying to listen to assist you, but we will package that in a document. Now, for those who spoke about access to the GEMS app portal, the QR code is currently on display. All you require there is just your BHF PCNS number, practice number, and then you will take it from there. It's not really a very lengthy one. And then we also have upcoming summits. As the scheme will be in Eastern Cape, If you are in those provinces, all of us on this call from GEMS side and the scheme and the SP, and that is Metropolitan and Med scheme, will also be there in person to come and spend the day with us. These are CPD accredited sessions that you will benefit greatly from the conversations that we'll be having. As indicated earlier, we have advised that we'll share email addresses. So the email addresses that are on display, I must say that the one that you need to copy, summit@gems.gov.za, is only for us at the scheme to monitor and get the data to assist us. So it is only open for 5 days, I think, after this event. After that, it is an unattended email address. But the other ones, the MESCHEM one, as well as the other ones below for claims, are available all the time. But the summit one is just to assist us to get a sense of what is going on there. So I'm appealing to everyone, please take note of that. And with that being said, I'm looking forward to seeing you all, and I'm hoping that you can assist us now with doing a quick feedback on that survey QR code, just to assist us so that we can ensure that when we meet next time, we are also able to attend to your various needs. And I must say, I'm sure that time when we meet, we should also be able to give you feedback from the task team and the discussions and the conclusions that were made there, and the position of the scheme, and also those who were involved on all the related matters, whether mental health and even others, as Dr. Miller also explained, that some of these principles will be applied across various settings within the healthcare. So with that being said, please feel free to assist us with that survey. It helps us to ensure that we improve on this webinar, so that next time when we meet, we're able to meet your expectation, and we understand that the time that you spend with us is a very valuable time that you could have spent attending to the clients that you have. With that being said, colleagues, I'm going to submit that we close the webinar for this evening, and looking forward to seeing you again, hopefully before the end of October, and trust that this was beneficial, but please help us to give us that feedback. Thank you very much. So the webinar has come to an end. Thank you.